The invitation, of course, to speak here. It's an honor, especially among such a distinguished panel of speakers. I will share some results of the PASER study, and PASER stands for Pan-African Studies to Evaluate Resistance. Initially, this was a network established by Pharmaxis, but currently I work at the Amsterdam Institute of Global Health and Development. PASER has done some important work on surveillance of HIV drug resistance in Africa. So as some context, we know that over 13 million people are on ART today, worldwide, and the ambition is to increase the number of people accessing ART. In addition to putting more people on treatment, of course, it's equally important that those who receive treatment also achieve virological suppression. And this is reflected by the 1990 targets that are currently set. So in light of those targets, the first question I want to address is, it's important to know how are we actually doing today in terms of virological suppression. And in an attempt to answer that question, I want to share the results of a systematic review that we've just completed, and this analysis was done by Sonia Bunder, looking at, or actually collecting data of 160 studies from resource-limited settings. And this slide shows that the on-treatment virological suppression rates on first-line ART by region, by resource-limited settings region, and the red bar represents the data from sub-Saharan Africa. So here you can see that actually over time, and this review looked at data outcomes up to 5 years of treatment, that on-treatment virological suppression rates actually remain quite high, between 80 and 90%, even up to 5 years after initiating treatment. What you can also see is that, let me see if I can point this, is that the confidence intervals at the later time points, at the 5-year time points, become very wide, indicating that there's really a lack of data to inform the summary estimates at those time points. So this shows quite a positive picture, actually, but this data does not account for any deaths or loss of follow-up that has occurred, because this really just tells about the patients who have been retained in care up to these time points. And the following slides shows our intention to treat estimates. And with this analysis, all deaths and persons lost to follow-up were counted as, or were considered as virologically failing. And there you see that the virological suppression rates really decrease over time to around 60% after 4 years of treatment. And here again, you see the very wide confidence intervals at later time points. And there was we were not able to make any summary estimates for the 5-year time points. So really, the conclusion is from this data that on-treatment rates look quite favorable, but intention to treat rates are, more concerning, and especially data on long-term time points is lacking. So drug resistance has, of course, been considered a threat to achieving virological suppression. As Professor Richmond said, it's both the cause and the result of virological failure. So my second question that I want to address is, what is the estimated rate of pre-treatment or transmitted or primary drug resistance in this region, in Southern Africa? Like we just heard, rates from Europe and the US are, well, probably between 5 and 10%, in some settings even up to 20%. What is the estimated rate for those for the drug resistance before initiating the standard first-line ART in Southern Africa? So the best data we probably have about this is a review that was performed by Ravi Gupta, published in The Lancet in 2012, and the PASER network also contributed data on pretreatment resistance for this review, and it collected data from over 26,000 patients in, again, resource-limited settings who were treatment naive, or at least supposedly treatment naive, or self-reportedly. And this next graph shows that the predicted increase in drug resistance. So this graph shows the time since ART rollout on the x-axis, and these bubbles that you see are actually individual studies, and the size of the bubble increases with the size of the study. And so according to the model that was used for this meta-analysis, the transmitted drug resistance rate at the time of rollout at time point 0 was around 1.4% in this region in Southern Africa, and increased with a 14% increase per year for all mutations, and the increase was higher for the NNRTI-related mutations, up to 23% per year. So if you would calculate that today, at least 10 years after rollout, the estimated percentage would be around 3 to 4%, but I've put some questions mark there. I mean, this is clearly an estimation, and also should underline that these bubbles, so the data that informs this model are individual studies from individual cohorts, so are not in any way nationally or regionally representative. And this is the rate for Southern Africa, and this slide shows the data for East Africa, where the increase was predicted to be sharper, with 29% for overall mutations per year and 36% for NNRTI-related mutations per year. But again, from this model, predicted rates around this time would be, let's say, around 5%. So all in all, that is still limited if you compare to European or US rates of pre-treatment or primary drug resistance. Next question is, what's the consequence of this rate of pre-treatment drug resistance? What, in other words, is the percentage of people who are infected with such a drug-resistant strain of HIV? What percentage will achieve virological suppression, let's say, after 2 years of first-line NNRTI-based therapy? So this data, the next slide that I'm showing, is from the PASER cohort and shows rates of virological failure and an odds ratio for virological failure in people without PDR, pre-treatment drug resistance, on the left, versus people with PDR, pre-treatment drug resistance, on the right. And you see that having this pre-treatment drug resistance before start of therapy more than doubles the risk of virological failure and subsequently also of acquired drug resistance. That's, those are the rates for virological failure, and in the red balloons, let's say, below are the rates for virological suppression. So after 2 years, again, this is 66% for people without pretreatment drug resistance, and as low as 42% in people with pretreatment drug resistance. So you can see this rate is really far away from the 90% target that we've set for achieving virological suppression. And of course, again, I have to say this is the data from the PASER cohort, which comprised about 2,500 people on first-line ART in 6 different African countries. And this was limited to the 13 clinics and cohorts that contributed data to that analysis, and of course is not nationally or regionally representative. So this is quite concerning, and after causing after virological failure has occurred, you can also see that if pre-treatment drug resistance is present, this also increases the risk of switch to second line. And this data was presented by Bernice Hoenderboom yesterday, and you see that the hazard ratio for being for experiencing virological failure and then also being switched to second line is 3.8 for people with pre-treatment drug resistance compared to those without. Just gonna take a sip of water. And so you see here that actually the presence of pre-treatment drug resistance really drives the uptake or the later need for second-line treatment. And this might have, large consequences for research-limited settings. This would suggest that since ART is being rolled out, more and more people are accessing ART, more pre-treatment drug resistance will occur, and also that would, according to this data, lead to more use of second-line treatment, so that would increase. But in fact, I think it will not just continue to increase, it will probably plateau, level off, and as also Professor Richmond indicated, as there's more access to effective alternative therapies, second-line second-line therapy, you can prevent continuing viral replication under antiviral pressure, and you can prevent more acquired resistance from happening, and then also subsequently prevent transmitted drug resistance. So we looked at the effect of increasing access to second-line treatment in a mathematical model, which is done by Brooke Nichols. And she compared different ART monitoring strategies and their effect on transmitted drug resistance. And the strongest reduction of transmitted resistance in this model was achieved by increasing access to second-line drugs. So switching over 80% of patients with continued viral failure on first-line therapy to second-line was the strongest reduction of pre-treatment drug resistance. And this, of course, is also, well, seen in this model, but also seen from the observations in resource-rich settings. So, second-line treatment, and also, as importantly, this model also showed that when you increase access overall, with higher initiating treatment at higher CD4 thresholds, or even as a test and treat strategy, the prevalence of drug resistance in new infections might increase, but due to the effect of reducing overall infections, the absolute number of transmitted drug resistance will decrease. So, in conclusion, many studies have shown that pre-treatment drug resistance in sub-Saharan Africa is likely to rise with more exposure to ART, but very importantly, drug resistance should never be an argument against early initiation, like I just indicated from modeling studies, and I think observational data will be coming out, is that since the number of infections will decrease, the absolute number of transmitted drug-resistant infections will also decrease. And important for the estimates, for the figures that we have now on pre-treatment drug resistance, is the fact that there are really no national estimates. And we've seen that drug resistance increases the risk of virological failure and then switching to second line, but this will not be an exponential increase, because if you do switch to second line, that will in turn then decrease pre-treatment drug resistance, and this calls for increased access to second line drugs. And from our systematic review, we've seen that on-treatment virological suppression rates are generally very favorable, but that attritions are real threats to ART programs, and that the long-term data is scarce, and also in this field of virological response rates and acquired drug resistance, national estimates, again, are really lacking. So I would like to thank the study team, the study participants, all the doctors, lab staff, data staff that has been involved in collecting this data, the PASER network, the AIGHD team in Amsterdam, Tobias, Ralf Hamers, Sonia, and also Pascal Ondoa, and of course also the funders, and especially currently the Netherlands Embassy in the Southern African region.